So let's see anaphylactic shock today. So anaphylaxis refers to Ig mediated immediate hypersensitivity reaction involving mast cell and basophil degranulation with release of histamine. So with histamine, other substances released are tryptase, prostaglandin, leukotrienes, and these are all arachidonic acid pathway products. So what are the causes of anaphylaxis? There are number of causes of anaphylaxis. Anything, any drug, any substance can cause anaphylaxis. So anaphylaxis is ag mediated reaction. Foods including nuts, eggs, fish, shellfish, even cow milk causes anaphylaxis. Antibiotic most commonly penicillin and cephalosporins. Others like vaccines, anesthetic drugs, insulin and other hormones, antitoxins, blood and blood products, insect stings and bites, snake bites, latex, etc. All these cause anaphylaxis. Anaphylaxis. Okay. Other is anaphylactic reaction. The basic difference between anaphylaxis and anaphylactic reaction is anaphylactic is not uh, Ig mediated, where anaphylaxis is Ig mediated. So in anaphylactic reaction there is mast cell degradation and it is not Ig mediated. So causes are NSAIDs, diclofenac or opiates, sulfites, contrast dyes, a neuromuscular blocking agent like succinylcholine, gamma globulins, anti-sera, and even exercise causes anaphylactic reaction because of mast cell degranulation. So what are the clinical features of this anaphylaxis? So now the different systems are affected in anaphylaxis, which include ocular system or eyes. There is pruritus, lacrimation, conjunctival edema, periorbital edema. Skin, it causes pruritus, flushing, urticaria, angioedema. In CVS, hypotension can be there, tachycardia is there, arrhythmia, cardiac arrest, and paradoxical hypotension can be there. In respiratory system, there is dyspnea, difficulty in breathing, stridor or wheeze, difficulty in swallowing, and pulmonary edema. Even laryngeal edema is there in some cases because of severe esterase deficiency. In GI system, there is nausea, vomiting, diarrhea, abdominal pain. Neurologically, there can be anxiety, sense of impending doom, uh, then pre-syncope and syncope, and ultimately patient may land up in seizures. So, what are differential diagnosis for this condition? Uh, Differential diagnosis are urticaria, asthma, Redman syndrome, which is caused by vancomycin, carcinoid, present with similar features, pheochromocytoma, mastocytosis, then panic attacks, and scromboidosis. Actually, the scromboidosis is nothing but because it is because of eating spoiled food or specifically fish which contain histamines. Okay, so how will you investigate anaphylactic shock? So there are few investigations: total tryptase, serum or plasma, then platelet activating factor, histamine, and mature bitter tryptase. These are the four investigation: tryptase, puff, histamine, and beta tryptase. So, what is management of anaphylactic shock? So, if you are suspending impending respiratory collapse, which can be manifested as stridor, wheeze, increased respiratory rate, dyspnea, or difficulty in swallowing. If impending respiratory collapse is there, what will you do? Immediate intubation. If it is there, immediate intubation and mechanical ventilation is the only way. Or if intubation is delayed, then we'll have to do cricothyrotomy or tracheostomy ultimately. If if it is not there, means there is no suspected in respiratory collapse, so what will you do? So treatment is monitor BP, pulse rate, SpO2, respiratory rate. Okay, and we must give intramuscular epinephrine or adrenaline in the dose of 0.3 to 0.5 mg, 1 is to 1000, anterior or lateral thigh, repeat every 5 minutes. If there is no response to intramuscular dose, then we will give IV epinephrine or adrenaline in the dose of 0.1 to 0.22 milligram every 1 to 2 minutes till response is there, or we will start infusion 1 milligram in 250 ml of dextrose at the rate of 2 to 10 microgram per minute. infusion 1 milligram into 50 ml of dextrose D5 at the rate of 2 to 10 microgram per minute. Okay. If patient is hypotensive, then we give 1 to 2 liter of NS rapidly. So if we are doing all these measures and patient, we will see if patient responds or not. If patient doesn't respond, what will you do? If patient doesn't respond, we will evaluate again. If patient is taking beta blockers, if patient is taking beta blocker, we will give glucagon 1 to 2 milligram IV or IM every 5 minutes and we will look for a response. If patient is in hypotension, we will give epinephrine 5 to 10 microgram per minute and aggressively we will give fluids. If patient has respiratory symptoms, we will give inhaled albuterol 0.5 ml in 2.5 ml of NS. Okay. If patient responds to above given treatment, that epinephrine, IM, IV, and IV fluids, if patient respond to this, what will you do? Every patient we will treat with H1 and H2 blockers. So most commonly used H1 antihistaminic diphenhydramine 25 to 50 milligram IV plus H2 blocker which are commonly used are Rantac 50 milligram IV and famotidine 20 milligram IV. Okay, so if patient respond, every patient should be treated with these drugs, these two drugs, H1 and H2 blockers. Okay, thank you.